Hello, and welcome to today's webinar titled Curating the Human Genome to Advance Identification of Rare Diseases. And we will be exploring this exciting topic within the context of screening by newborn sequencing. My name is Tamara Ibarisha, and I'll be your host today, so let's get started. The Mastermind genomic search engine is the most comprehensive source of genomic evidence and can be used to quickly identify the information needed to support patient diagnosis and treatment decisions. In today's webinar, our speakers will discuss how a unique balance of AI and expert review is used to generate a solid foundation of high-quality evidence for understanding the genetic basis of a disease. They will then discuss how this approach is being used to assess and classify every variant in the human genome, starting with newborn sequencing applications. I'm really looking forward to the discussion of today's topic, which will be interesting, especially for those of you who are involved in newborn screening efforts and decision-making in the clinical setting. Today's presentation will include demos using the professional edition of Mastermind. So if you don't already have a Mastermind account, you can create one today at the bit.ly link that you see on the screen. This will start you off with a free trial of Mastermind Pro so that you can follow along and conduct searches similar to the ones that you will see today. We have a lot of great information to share with you, so I'd like to cover some basic housekeeping and then I'll get to the introductions. If you are joining us live, feel free to drop questions into the Q&A, and if we have time, we will cover those at the end of the webinar. Also, this webinar is being recorded and will be emailed to you at the conclusion of our session. Now I'd like to introduce our speakers. We're joined today by Dr. Mark Kiel, our co-founder and Chief Scientific Officer. Hi, Mark.
Hey, Tamara, how's it going?
Good. Mark oversees scientific direction and product development and founded Genomenon to address the challenge of connecting clinicians and researchers with evidence in the literature and to help diagnose and treat patients with rare diseases and cancer. We are also joined by Brittnee Jones, our Director of Customer Success. Welcome, Brittnee.
Good morning, everyone.
Good morning. With over a decade building and leading customer success teams across the NGS space, Brittnee ensures rapid product adaptation and maximal value for Mastermind users. So thank you both for being here to share your expertise. Before we get started, I'd love it if each of you could share a little bit more about your work at Genomenon. So Mark, we'll start with you. Could you give us a sense of where things started with Genomenon versus where we are today?
Sure, I'd love to, Tamara. Thank you for the opportunity. Many of you in the audience may not know the origin of the word genomenon. It's a Greek verb that means born out of need. And so about a decade ago now, when I was in graduate school, I was doing research profiling different cancers using exome and genome sequencing. And I was frustrated by the need that I had to go out and find information about these variants that were seen in the patient samples that were sequenced. And then about 2 or 3 years later, when I entered my clinical pathology residency, I was even more frustrated when I found that for diagnostic purposes, I had that same need. And so Genomenon was born out of that need. And I like to talk about Genomenon in an evolutionary arc. Genomenon 1.0 being aggregating this data, Genomenon 2.0 being annotating this data and presenting it in the Mastermind interface, which we'll be talking about, which Britt will be demonstrating. And then we increasingly had the call to have this data not just organized computationally and presented in a user interface, but curated. And we curated that data one gene at a time as needs demanded from our different clients on the clinical side and in our interactions with pharmaceutical clients. Genomenon 3.0 is now the full embodiment of that curation exercise to include the entire human genome. And the beginnings of that endeavor are what Britt and I will be showcasing, me in slides and her in the demonstration portion of this webinar. The disease-specific curated content with an immediate focus on rare diseases such as those associated with newborn screening.
Excellent. Thanks so much for sharing all of that. So Brittnee, let's turn to you. Could you share what it's like to work with many of the clinical and pharma customers who are using Mastermind data?
Yeah, absolutely. Again, thanks everyone for joining us this morning. And I'm probably going to start by riffing off a little bit of what just Mark just said, which is I really love my job and what we do. It really is, there is a need in the clinical space that is the bottleneck in terms of curating variants. My background is I was working with labs doing that type of curation and seeing how long and how hard it was to find all that literature. When I was approached by Mark and the team and actually ended up joining Genomenon, I think the first thing I said is something to the effect of, oh, thank goodness someone's finally doing that, right? This was a key component of classifying these variants and of these rapid diagnoses that many of our customers are looking for. We get to work with companies and groups that are really changing the course of progression of these diseases, or changing the course of the diagnosis of these diseases, which is incredibly fulfilling and wonderful to see that work as they continue to want to get more rapid and turn around these cases even more quickly. That's where we started looking at this curated content. That's really where there was a need to speed this process up even more. And that's really where we're pushing. We're pushing at the forefront of trying to, work with labs, talk about their workflow. How can we even automate some of these processes? That's a whole nother conversation we won't really go into too much today. But how do we turn around diagnosis for these rare diseases, for diagnostic odysseys as quickly as possible, to then move into treatments so that we can halt or slow the progression of disease. So yeah, I really love what we do and love working with our clinical customers.
That's great. You two have set the stage wonderfully for our really interesting discussion that we're going to have today. So Mark is going to kick us off with an overview of Genomenon's endeavor to curate the human genome, and we'll highlight the contributions of our work to the Beginnings Initiative at Rady Children's Institute for Genomic Medicine. Then Brittnee will join the conversation to show how variant classification and supporting evidence is presented in the Mastermind genomic search engine to enable rapid identification of newborns at risk for developing rare diseases. So with that, I'll hand it over to Mark to get things started.
Thank you so much, Tamara. I'll go off camera so the slides can be seen larger. For my portion, as Tamara described, I'll be setting the stage for Brittnee, who will be showcasing the fruits of our curation at Genomenon, and specifically those genes and diseases associated with diseases of infancy, particularly that are pertinent to newborn sequencing. She'll be showcasing some of that in our user interface, but I'll be setting the stage more deeply than we just did in the preamble here, beginning with Genomenon's mission. So I landed on the slide showcasing our team because Genomenon is a very people-first company. People, and particularly patients, are at the center of all that we do. Our mission, which we are driven by in our ambition to curate the genome, is to save and improve lives by making genomic information actionable. And as I alluded to in the discussion of our evolution, the technology that Genomenon has developed is put to the service of aggregating genomic information from the primary medical and scientific literature, both at the full text level as well as in supplemental tables across the decades of such inquiry, both scientific and clinical studies. And our computational capability uses algorithms to annotate this information. Very sophisticated, very robust algorithms that we've developed in-house over the past decade, with an increasing number of talented individuals refining and modifying and expediting the pace of those algorithms and their ability to capture this information. But as I said, the other side of this human equation is the curators on our team, 40 plus curators now, who are reviewing every single one of these assertions and every one of these references and making determinations using their clinical and scientific acumen to ensure that the data is accurate. And our AI and those human curators have the goal of organizing this information into genomic associations. Those associations could be fit to the purpose of variant interpretation, as we'll be focusing on here, as well as understanding the way diseases are caused by genes and their genetic variants. So we have two lines of business that we realize value from our aggregated and curated data. We'll be focusing on the clinical aspects of our business, improving and streamlining workflows, but we also have business in putting our data and the insights in our data to purpose for facilitating drug discovery. So in the clinic, we increase diagnostic yield and streamline variant interpretation by providing the evidence necessary for clinical work and screening, such as I'll be speaking to specifically here toward the end of my presentation with respect to newborn sequencing. On the pharmaceutical side of our business, we produce variant and patient landscapes, which are a comprehensive reflection of all the disease-causing variants published in the medical literature or in associated databases, with all of the requisite ancillary data from databases necessary to accurately interpret those variants, as well as cataloging the patients and their genotypes and their phenotypes and their clinical presentation, which is helpful when designing clinical trials, understanding inclusion and exclusion criteria, determining appropriate endpoints for disease depending on the mechanism of action of your drug, as well as increasing awareness of your trials and commercial drugs. But today the focus will be on the disease-specific curated content and its application in those clinical workflows. So let me begin by setting the stage a little bit more, recalling your minds back to about 10, 15 years ago, when we as a field were faced with this happy challenge of the genome sequence from the Human Genome Project having been completed, and there being this beginning of a next generation DNA sequencing revolution, which promised and has delivered on the promise of having a $1,000 genome, such that there's no longer a bottleneck in producing this data. And as you well know, sequencing has long since become a commodity, but there nevertheless, as foreshadowed when I was a grad student and a little bit beyond, this challenge of the interpretation of that data. So this has been referred to as the $1 million interpretation, which may be an exaggeration, but it really underscores the importance of this interpretation challenge. It's also referred to as the bioinformatic bottleneck of really using the data that we have at our disposal in the service of understanding what any of this data means in the clinic or in research labs or in the service of informing drug discovery. Specifically with respect to the challenge in the clinic, it's vitally important to have all of the information, all of the evidence at the disposal of the variant analysts, geneticists, and pathologists who are charged with accurate and efficient interpretation of this data. A missed or delayed or erroneous diagnosis can be extremely consequential in cost measured in dollars or in cost measured in quality of life or even years of life for these individuals who are being sequenced in the clinic. And that was really the challenge that I wanted to rise to when I founded Genomenon, and that I know, as I mentioned earlier, is really motivating all of the people at Genomenon who are rising to this interpretation challenge. So let's break this out a little bit. Let's parse this challenge as we did early on at Genomenon and continuing into the present and moving forward into the future. The way that I like to parse this challenge, given my background as a clinical pathologist, is into sensitivity, making sure that you have all of the information you need, and specificity, making sure that that information is appropriate and accurate. And then finally, balancing those two with the interpretation of that data being fit to purpose, either diagnosis or screening or research. So you'll see me have three main components to the talk: sensitivity, specificity, and then bringing those two together with a specific use case around newborn sequencing. So beginning with the sensitivity challenge, as you well know, there is a proliferation of information in the medical literature. The medical literature being highly unstructured, even when we're talking about data tables. There are idiosyncratic formats, and there's wide distribution of this information. The information is cataloged by humans in English language, and there's guidelines for how to lay out the genomic variant nomenclature and the way to talk about diseases and genes, but those aren't very often adhered to. And so not only is there a proliferation of this information with the commoditization of sequencing and the ability to understand the genomic causes of these diseases from a research perspective, but that information is being disseminated in these unstructured references that are really important to be capturing and cataloging for diagnostic purposes. So the solution to this problem that we feel strongly is necessary is to apply artificial intelligence or computational intelligence to solve the sensitivity challenge, which is to say, to ensure that nothing that is needed is missed. So I want to linger a little bit about this concept because AI is easily misunderstood by people, groups, companies who aren't practitioners of AI. So AI is a very broad-based term, artificial intelligence, and I want to clarify the specific nature of the artificial intelligence that Genomenon uses and how it figures into our concept of making this data actionable and making it not only widely available, but applicable to the different use cases for that data. So AI, in lay terms, is misunderstood to be a black box where the computer will figure it out. There are recondite algorithms of unknown provenance that nobody knows what they're doing. And that's a increasingly recognized problem within the field of AI itself. And particularly in genomics, I and my co-founders and early employees recognized that it would not be a viable path forward in clinical medicine, especially in a very focused area like genomic clinical medicine, where evidence is paramount. And so in this field of AI, there's the necessity now to show your work, to show what the algorithms mean and how they reach their decisions. And that very much is our philosophical approach to our computational intelligence. It definitely does not stop there, as we will be focusing on in the next section of my talk, and Britt will be focusing on her demo, because we strongly believe that there's a necessity for human review of that data, whether it's by the end user of our Mastermind software or by our internal curation team or by those two groups united in reviewing and annotating and presenting and assessing this evidence. So you'll hear me speak to that here in subsequent slides, but beginning with the computational approach. Our computational approach is referred to as genomic language processing, and it was built from the bottom up by Genomenon's developers, and it brings order to the chaos of that unstructured data, the needful genomic insight from the medical and scientific literature. So on the left here, I'm showcasing that literature and its genetic and clinical content, which you can see here is reflecting diseases seen in patients, the phenotypes that they present with, the therapies that they have been treated with, and critically for our users, the genes and genetic variants that are associated with those patients across all of the publications that cite any one of those entities. And Genomenon's genomic language processing is a very sophisticated set of heuristic capabilities that we built from the bottom up to recognize these named entities. So that aspect of artificial intelligence is referred to as named entity recognition. And it begins with amassing that corpus or body of information, the full text and supplemental data of the genomic articles that we keep up to date by the week, where all of this needful information is. And our AI culminates in recognition of these terms in the middle and organizing them into those genomic associations, the genes and the variants and how they cause diseases and with what phenotypes those patients present and the therapies that they've been treated with. So that's a summary of our artificial intelligence capability. And the way that many of you are familiar with seeing that work, the fruits of that work, is in the Mastermind user interface. So Tamara already introduced this. I just want to linger on a couple of aspects here. It is the most comprehensive such catalog of this needful genomic evidence, comprising 9 million full text articles and growing by tens of thousands per month. 3 million supplemental data sets with prioritized genomic content, culminating in the recognition of tens of millions of genetic variants, using those highly sensitive, very sophisticated algorithms to allow our end users to rapidly identify the scientific and clinical content that they need to inform their diagnoses, thereby accelerating those diagnoses in their workflows and facilitating treatment decisions by pointing those users in the clinical labs to the primary source material. This is what that looks like. I'll just spend a little bit of time orienting you. Britt will do a live demo and we'll repeat some of this. But on the left, for any gene that is searched, is all of the variant content, very comprehensively depicted visually and in list form for every variant, for every reference in that entire scientific and medical literature corpus. On the right are all those citations, and at the top, as Britt will demonstrate, are various different search parameters that our users can use to refine their search criteria. And Genomenon's Mastermind is the gold standard in diagnostic support software for genetic and genomic diagnosis. We have a global footprint with 140 countries represented, you can see on the map, and tens of thousands of end users across thousands of different diagnostic labs, both academic, commercial, reference, large and small. Some of our better known users are presented at the bottom, but again, this is a very vast global clinical diagnostic network comporting with our status as the gold standard in this diagnostic software. The benefits of Mastermind, as you'll see highlighted in examples in Britt's portion, is leading to reduced turnaround time, increasing diagnostic yield with not just more variants, but also more content, and allowing end users to scale as their caseload grows, which is, as I said, is where artificial intelligence is necessary to organize this data and present this data within seconds of an end user search, providing them with access to this comprehensive reflection of evidence across the entire genome. Recently, Anna McGill, a colleague of mine on the curation side, and I presented the recent integration of the ClinVar data into the Mastermind offering. So now it's a reflection not just of the literature data, but also of those variants that are encountered in clinical practice. So I'd like to say Mastermind is a superset of the variants that have been encountered in clinical and research circumstances, those that have not been published and are present nevertheless in ClinVar, as well as those that are published but are not yet present in ClinVar, which is a substantial fraction of those variants. So ClinVar is a valuable resource, as those in audience well know, for identifying these clinically encountered genetic variants, but there are limitations to its utility. Many of the variants are missing, as I mentioned, and we'll showcase in a data slide here coming up. The variants that are present in ClinVar skew toward benign or otherwise variants of uncertain significance. And this is an important distinction to drill deeper into. This is because of the nature of the variants that are submitted. It has nothing to do with the conservative or liberal interpretation of the variants by the submitters of ClinVar or the publishers of variants in the literature. It has much more to do with the core nature of these variants. For instance, a large fraction of the variants in ClinVar are benign polymorphisms, or are incidentally encountered deep intronic variants that don't have any association with disease. Those are potentially important variants and useful if you encounter them in clinical circumstances to identify those variants and say recognize that there's no evidence of pathogenicity for those variants so that you can safely move on. And that's where ClinVar is a valuable resource, is in the collection and cataloging of those incidentally encountered benign variants or otherwise variants of uncertain significance. But among those variants that do have pathogenic import, ClinVar is missing a substantial number of reference citations. So among variants in ClinVar, fewer than 25% of them have variant-specific evidence citations. So that's a really critical gap that ClinVar has, where it's a valuable resource, where the integration of ClinVar into Mastermind can provide a benefit greater than the sum of the parts. Further to this, ClinVar fails to reconcile many conflicting designations, variants that have conflicting evidence, or in this case with ClinVar's conflicts, where different submitters have different determinations about the import of the variant. And I'll showcase that shortly here by way of example. And finally, as you may well recognize, ClinVar submitters have a challenge of a lack of consistency in the way diseases are annotated across the ClinVar variant dataset. So the integration of ClinVar into Mastermind complements those deficiencies of ClinVar and strengthens the value of the utility of Mastermind for finding these variants and finding and reviewing the evidence for each of these variants. Mastermind is highly sensitive in identifying that clinically relevant published variant data set. There's a selection for pathogenic and case-related variants. Again, by their very nature, those variants tend more often to be published, whereas the benign polymorphisms that are incidentally encountered in routine clinical practice and sequencing are not published. So of all the variants in Mastermind, there's a tendency for all of those by their very nature to in fact be pathogenic and case-related. And Mastermind, as I've emphasized, is a comprehensive cataloging of not just all these variants, but all the evidence citations for each of those variants, and thereby provides an unbiased evidence catalog to reconcile those conflicting designations, as well as to better determine what the disease annotations and associations should be. So there's great benefit to the integration of ClinVar into Mastermind, including ease of searching, increased diagnostic yield, increased evidence to increase confidence in your calls, including correcting or converting calls with that evidence. So here's an example of the data in Mastermind compared to the data component in ClinVar for a representative gene. This is a busy slide. I apologize, but let me walk you through it. On the right, in the pale blue circle, are the ClinVar variants. On the left are the literature variants found in Mastermind, with the crescents around the overlap reflecting variants that are only found in ClinVar or otherwise only found in Mastermind in the literature. And for each of those that are in on the sides and the crescents, you can see the distribution of the calls made by the ClinVar submitters or otherwise made by our curators, which I'll focus on that process here in the next section. And you can see with that breakdown, there is a skew toward those benign variants, those polymorphic variants, or otherwise variants that are variants of uncertain significance, because they're lacking that evidence. So ClinVar only variants there are lacking any evidence from functional and clinical studies from the literature. In contrast, on the left, the variants that are found in literature only, as assessed, as I'll walk through by clinical standard guidelines, are adjudicated to be pathogenic in the main because of their very nature, because they're published, because they're associated with diseases and patients with those diseases. And similarly, for those variants of uncertain significance, though they don't meet the threshold criteria for being designated pathogenic, they nevertheless are associated with cases. So there's a very important distinction there to say that there's valuable information in variants that are only seen in the literature, and there's a substantial number of those variants, as you can see in this representative gene. The other thing to focus on in this diagram is the middle, the shared component, where there are variants that are both in ClinVar as well as found in the literature. And one thing to highlight there is some of those controversies or discrepancies where there's reason to have different labs and different variant scientists disagree about the pathogenic nature of a variant. Genomenon's philosophy is that the evidence should be the ultimate arbiter of that information. And where there's a substantial overlap in agreement about the pathogenicity calls for those variants, there is still some disagreement, and that disagreement can be a significant fraction of variants. And again, the value of integrating ClinVar into Mastermind is the evidence necessary to reconcile those discrepancies for that fraction of shared variants where there's a disagreement in calls is right there for you, just a search away in the Mastermind interface. So moving now into the second component of the talk, here I want to focus now on specificity. And I alluded to Genomenon 2.0, where we talk now not just about computationally organizing and presenting this evidence, but curating it to ensure that the data is accurate. And that curation requires a human. There's no way around it. I mentioned earlier that genomics and aggregation of this data isn't feasible without computational capability. So there's a necessity for artificial intelligence, such as I described with respect to GLP. Just as necessary is this human component of accurately interpreting this information. So that two-phase approach, computation for sensitivity and curation for specificity, is a strong driver behind Genomenon's philosophy for organizing and presenting this information. So curation by experts, in particular the 40+ expert curators on our team, is necessary to ensure that these calls are correct. So those curators that I've alluded to here are genetic counselors by training, or otherwise have master's level degrees in genetics and variant interpretation, as well as PhDs in specific disease areas, be they rare disease or oncology. That's the team that Genomenon has built in the service of presenting this disease-specific curated content, which Britt will demonstrate. So when I say disease-specific curated content, what I mean is for any given gene that has been curated, every published variant and every pertinent reference citing any one of those variants, as well as any relevant database entry, has been reviewed by our human expert curators and reviewed according to ACMG and AMP standard clinical variant interpretation guidelines. So when I say reviewed, I mean literally the published evidence is looked at and assessed just as you would in clinical workflows. And what results is a provisional call that we're presenting to our end users for those curated genes through this disease-specific curated content in Mastermind. So it definitely bears iteration, repeating. Genomenon's philosophy here is using a combination of computation and curation. The GLP at the top for sensitivity to make sure that we're not missing anything, and then the expert human review at the bottom using sophisticated curation capabilities that allow us to not only be very accurate in our curation, but to be highly efficient, allowing us to curate this data at unprecedented scale. A little bit about the ACMG AMP framework, which you may be familiar with. It is a codification of the way that the evidence should be curated, be that evidence from population databases, predictive models of pathogenicity, or publications and the evidence for functional and clinical significance. That has all been codified, and we're using that internally in our curation infrastructure to ensure that the data, the evidence is all organized and accurately assessed. This is just a schematic of that breakdown where I can focus in the middle there on the, on the left in the literature component, where there's a key value proposition that Mastermind and Genomenon provides, where there's that necessary evidence from the published literature. The functional studies, the in vivo or in vitro functional studies, as well as the clinical studies, whether they're cohorts or cases, meta-analyses, families and pedigrees that have a segregation with disease of these different variants, all of that information in our curation workflow is assessed. So again, just to reiterate, this is a unique proposition that Genomenon provides: AI for maximal sensitivity and expert review for maximal specificity. This is to showcase or foreshadow, rather, some of the disease-specific curated content that Britt will be bringing up. So for any one of these variants that have where the gene has been curated, you'll see the fruits of that human expert variant curation. So the last part of my section that I want to focus on is balancing the two, ensuring that the data is both maximally sensitive and maximally specific, with a particular focus on the applicability of this data for newborn sequencing. So I like to say that the power of our comprehensive curated evidence is twofold. One is it ensures that the maximal number of variants are identified, as you saw in the Venn diagram for the ATP7B gene. It's making sure that all of those variants are identified, lifting this bell curve of variants up, but then also shifting them right with more evidence. The more evidence that you have for a variant of uncertain significance, the more likely there will be a clinically significant study, whether it's a case, a cohort, a functional study, that variant can then be promoted with evidence to likely pathogenic. So up and to the right is the value of this comprehensive curated evidence. And in the service of maximizing diagnostic utility and increasing diagnostic rates, this data is invaluable. And one particular example of that value is reflected here. This is a rare disease gene, the ENPP1 gene, which when mutated causes generalized arterial calcification of infancy. And this particular variant is the most prevalent such variant among diseased cohorts of patients with this Gacy disease. And I bring it to your attention because the call in ClinVar is listed as conflicted, because there was a single user who submitted that variant as a variant of uncertain significance. And that may very well have been an accurate call. For that circumstance, it could also have been an inaccurate call. The evidence for either of those is not forthcoming because there's not a lot of information surrounding that submission. But Gacy is just one of many diseases that can be caused by ENPP1 deficiency. And it's possible that this variant seen in that patient was not the right disease variant association, leading the submitter to submit a variant of uncertain significance call. It could also be that that submitter was unaware of the evidence supporting the pathogenicity of this variant. The bottom line is that ClinVar has this very important, highly prevalent disease-causing variant for this devastating disease of infancy, where early recognition and intervention is critical to save the lives or improve the lives of these patients. It's not appropriately cataloged in ClinVar. ENPP1 happens to be one of the disease genes that we have curated, and the curation of this variant, based on the evidence, is clearly pathogenic for the Gacy disease. Here is some of that evidence, and it includes not just clinical evidence, such as you're seeing in the upper left of segregation with disease in a family, but it also includes functional evidence, where this variant has been tested functionally to look for the functional outcome of mutating the ENPP1 gene product with this particular variant. So there's ballast to support our assertion that this is a disease-causing variant to overturn that ClinVar call. And Britt will showcase other such similar examples in her demo. So to bring it home on this section, the benefits of integrating disease-specific curated content are identical to the benefits of integrating ClinVar. There's an ease of searching for this data, seeing as you do now the evidence pre-annotated, pre-organized, pre-categorized, and clearly displayed at the sentence level with reference citations and disease annotations to rapidly inform your diagnostic decision making. The increase in the number of variants and evidence for each variant leads to an increase in diagnostic yield, and as I showcased, can be really helpful in overturning conflicted calls, again, with that evidence predicate. So in the last quarter of the presentation, I want to focus now on newborn sequencing as a specific application of the value of this large-scale data organization and evidence curation, and its applicability to ambitious projects with clinical ramifications. So just to get everybody up to speed, newborn screening is an enterprise that identifies individuals at risk for having genetic disease. And using biochemical assays for newborn screening has been a triumph of public health policy. It has been invaluable and has been widely recognized as saving numerous lives by early recognition of disease from a population screening perspective. It's not going away anytime soon, nor is there any intention from those interested in promulgating newborn sequencing to overturn the use of newborn screening. Rather, it's how to blend these two to maximize benefit to patients with this new genome sequencing capability. Application of genome sequencing to newborn screening is able now to broaden the diseases being screened, including identifying individuals who are pre-symptomatic, as well as, from a practical perspective, homogenizing testing across labs. So newborn sequencing, I and many others strongly believe will be an important emerging adjunct to newborn screening, but many challenges remain, from the technical to the ethical. The technical, and in particular, the data interpretation challenges where Genomenon is really weighing in our collaborations with a number of groups across the world who are focusing on pilot studies. So we're at the pilot stage. These pilot programs are collecting and assessing data in increments to assess the sensitivity of this approach for not missing individuals with disease, as well as the specificity of this approach to ensure that there's a minimization of false positive calls and an undue burden to the healthcare system and to the patients and their families who may be falsely identified as having a disease. That's a real challenge and is addressable by focusing attention on the specificity of the genome sequencing data. To assess the overall impact from a quality of life and patient lives perspective, as well as to figure in the cost and the time of this apparatus and compare it to the gold standard, which is biochemical newborn screening. Of all of these challenges, of all of these goals that we're seeking to gather data around, the most important challenge is variant interpretation. There are many challenges, many important challenges, but I strongly feel that the variant interpretation challenge is, if not the most, it's among the most important. And this view is echoed by a number of key opinion leaders in this space. So there are not just data challenges, but workflow challenges for newborn sequencing. Real-time variant interpretation is not feasible for newborn sequencing if we're going to meet those economic and temporal requirements of these programs. The infrastructure that we have is inadequate. There's not enough analysts, they don't have enough time, and there's too little coordination across labs. And this has been corroborated by many of my conversations at industry events and focused consortia, as well as in my private conversations with colleagues in newborn sequencing and genomic medicine. In order to meet these budget demands, the timelines and the financial constraints for large-scale newborn screening by sequencing, we need a completely different approach. And that approach is to catalog a database of every actionable variant interpreted in the context of screening, functioning as a lookup table. And if you didn't join late, if you've been listening to the slides that I presented earlier, Genomenon is uniquely suited to rise to this challenge. And in fact, our ambitious goal as a company is to curate the entire genome, beginning with these diseases that are applicable to newborn screening or newborn sequencing. So what do I mean when I say curating the entire genome? A fully curated human genome will allow us to achieve these goals for newborn sequencing by curating for every disease, for every gene that causes those diseases, every single variant ever published in databases or in published literature, by reviewing every one of those references with expert human curation, by aggregating all that database information that is a necessary component of that interpretation, and interpreting those variants provisionally according to those clinical guidelines, and then making sure that all that data is annotated and clearly displayed for end use. So when we talk about a fully curated human genome, we're talking about leveraging the computational component and our curation component in the context of its use, the use of that data in newborn sequencing. And we're working, as I alluded to, with a number of groups across the world. Two of them are showcased here, Rady Children's Institute for Genomic Medicine, as well as the Eden program from the CDC and others. We are leading the way as the evidence provider for all of these variants to surmount this very significant challenge of variant interpretation at scale in the service of newborn sequencing in practice, beginning with these pilot programs. So this is my penultimate slide here before I turn it over to my colleague Britt. The Rady program is referred to as Beginnings, and their goal in this is to end the diagnostic odyssey, and that's a shared goal with Genomenon. And my optimistic view of the near-term future for genomic medicine in this context is that as more sequencing is done, more evidence will be published, including the fruits of these pilot studies, and more of these cases will be published and submitted to ClinVar, leading to a continual improvement, a positive feedback loop of more and more and better, more and more refined evidence for newborn sequencing to culminate in more patients' lives being positively impacted. And that begins with our discussion of disease-specific curated content. As I said, we're systematically curating the entire human genome, gene by gene, every published variant, every pertinent reference for every one of those variants, manually reviewed by our experts, incorporating any relevant database data, and doing so all according to those clinical guidelines, and showing our work as is necessary when you're using artificial intelligence capabilities at this scale. And I will turn it now over to my colleague Britt, who is going to focus on some demonstrations of specific examples of this disease-specific curated content and how it can facilitate your own clinical workflows.
Thanks, Mark. There we go. I think everyone can now see my screen. Kate from our team was nice enough to go ahead and drop in the chat a link, the bit.ly link to sign up for Mastermind. When you click on that link, it's going to take you here to our homepage, which is mastermind.genomenon.com, whereby you'll be able to create an account and log in for your very first time. Once you're on this page, we have several examples here. This is how we're going to engage the Mastermind genomic search engine. As Mark had talked about and introduced for us earlier, simply by typing some type of information, right? In this case, I've typed a single gene symbol. The system recognizes, takes that information that empowers the genomics language processing that he spoke about earlier, and we will look for every way in which that gene symbol, in this case, is represented in the literature. So we're going to be able to look for legacy gene symbols. When I add a variant, we'll be able to look for all transcripts, known transcripts with changes at those positions. Right? So this is a incredibly comprehensive search that we're launching simply by ensuring that the symbol, the variant, something is recognized here. First thing I'm actually going to walk us through is this bottom right example. I just want to go ahead and use the example on the demo page so that you can understand where to find some of these types of examples of our disease-specific interpretations or curated content. So when I go ahead and click on that, you can see that pop up here. This screenshot was incredibly similar to one that Mark actually showed in his talk. And what you'll see here at the top, is that we've got a variant in ATP7B. We have classified, or we've given a provisional classification of that variant as likely pathogenic for Wilson disease. We do some amount of just a brief snapshot of the different evidence we've engaged here at the top. To view that, and I'll go through some of the other functionality here at the bottom later, but I'm going to focus here in the beginning on the actual curated content. So to view all of that evidence, I'm just going to click on that View Interpretation button right there. We understand that the needs of a lab, and I alluded to this in the beginning when I gave an introduction, is to expedite variant classifications, where the largest bottleneck is finding evidence. As Mark has talked about, we built a series of algorithms to serve that evidence sensitively to people that then go through and try to give the most relevant information in summary form to show our work. They're trying to show to the clinical labs what they found in that article so that the clinical lab can go and review it. That's why we continue to call this a provisional classification, right? Our team went through the 11 Mastermind articles right here that were served to them. These, and I can see this here by the different categories of evidence here, there are 5 total articles that our team found for these different criteria that I'm highlighting here. So PS4 on the left side and PS3 on the right. And these are actual text snippets from the article. So these are fragments of the article that a reviewer can go and look at, can go find that in the article if they want to review more information. So this is really about us showing our work, right? As Mark has said several times, we're really trying to give you a short list of articles to go and review so that you can determine the pathogenicity of this variant in your lab, along with us providing that provisional classification there. For this one, we also, I should say down here on the left, I do want to show that we also show other information that's relevant to this classification. We're bringing in that ClinGen information for the disease here. We're also showing you nomad frequencies, predictive scores, right, for PP3, and then information about PP2 down here where missense variants are a known mechanism of disease. For this variant, obviously we've seen this as likely pathogenic. In contrast, and Mark did a really good job introducing, so I won't go too much into the ClinVar information here, but this variant was last seen back in 2018 and classified as an uncertain significance variant in ClinVar, though our team determined that that's likely pathogenic here. Most likely that's because, again, that evidence, I guess not surprisingly, these are rare variants typically, these are rare disorders. You know, you're not going to see all of these variants very frequently. So the last time someone deposited that in ClinVar was 2018, really, which is, you know, means it's kind of out of date. We're going to be updating these classifications very frequently, up to a year at a time. Our last update on this one actually was just at the beginning of last month. So this information is really actually quite up to date, especially given that, you know, we even added down here a publication from February of 2022 when we did that update. So that was really just kind of an overview of the information that one can find on this. Now I'm going to go into a few more specific examples, highlighting some of the information that we find for different variants. Again, I want to make sure that I engage that genomics language processing engine, having the system recognize that. For this variant, what I really want to highlight here, in addition to, again, that summary type of information we're giving at the top, there's actually one piece of information that's not necessarily just about this variant, right? As part of the ACMG scoring criteria, because again, our team follows those criteria or those guidelines, there's actually a different missense change that is also pathogenic or likely pathogenic at this position. To find out what that is, what other variant we're linking, I'm going to click, I clicked on this little drop down right here on the left. You can see that there's also this other variant that's been determined to be likely pathogenic. One of the reasons this is highly important for this variant specifically is, there's only, in terms of clinical evidence, an individual compound heterozygote case. And we'll look at that in just a second. But in that way, I may need to use information about this other linked variant here in order to support and find all the evidence necessary to classify this variant as pathogenic. To again review this case right here, I'm going to go to that view interpretation page here of screen. And what you'll actually see is that we have something here that we've designated as a PPC compound. Right, so there's an individual compound heterozygous case. To understand more about what that means when we designate something as PPC compound, again, just for transparency, we are always trying to show all of our work and show how we determine pathogenicity of these variants. I can actually download the SOP that our curators have used right here. I'm going to go ahead and share that SOP in true, baking style. You're actually seeing that SOP that I've previously downloaded. I went ahead and just found that PPC. What you'll see here is this criterion is actually applied when a variant's identified in a single affected individual in one publication. The compound then designates the actual zygosity of that variant. And as noted here, you'll see if we found this in more than one patient, meaning more than one study, and those patients are unique, that's when we actually go ahead and engage that PS4. So this is just to show that we are showing evidence, even if it's not necessarily 100% sufficient to designate the classification of a variant, we're still going ahead and showing you that evidence. We want to make sure that you can review all of those articles. At any point, all of the articles that haven't been used as part of this classification are easily found, again, just by looking at the articles that our team then reviewed. Right? So here I can go back and say, let me see evidence for this variant. I, in fact, for myself, want to look at these other, some other articles that were seen here. So I hope that highlights some of the other additional work that we're showing, so that you can review, the user can review these classifications, can review all the evidence that our team saw and truly support that, or truly come to trust our team with these classifications, right? So what we're trying to build in all of this is that we're trying to build trust. On this one, I also wanted to highlight one additional thing. This is where ClinVar, right? So that would be another piece of evidence, as Mark has said, these two are completely supportive of each other. We really want to show ClinVar as another way of, another piece of information or evidence to be reviewed as part of classifications. Here in this ClinVar tab, someone did in fact classify this as likely pathogenic, and I can go view that in ClinVar. As you recall, we had one not quite sufficient, fully independent sufficient article or a piece of evidence for this variant. Over here, we can see, in fact, there were no evidence added for this variant. But again, this is another piece of evidence that could support that pathogenicity call. This is a reputable institution also classifying this variant as likely pathogenic. For the next variant, I wanted to highlight, goodness, sorry, copied that a little bit wrong. As you can see, there's many changes at that same position. For this variant, the one thing I really wanted to highlight here is that, I'm going to go over here into view interpretation for this. And I'm going to highlight the ClinVar information here up top again. For this, there's an uncertain significance variant. This really proves that using the ACMG scoring criteria is by far the most standardized and best way to go through these types of interpretations. Right, so our curated content here says this is a likely pathogenic variant. In fact, there's quite a few pieces of evidence for this variant. The ClinVar data shows this is uncertain significance, but as recently as May of this year. If I go out and look at that ClinVar evidence, though, what I'll find is that this was classified as uncertain significance through Sherlock, right? So this is through another type of classification system with only a reference for that single type of classification. So this is really where Mastermind can supplement ClinVar classifications and show, again, all of the evidence for these classifications according to the ACMG scoring criteria. Right? So in this case, we had 12 different pieces of evidence for this single criteria here. To see all of them, I will highlight here in the user interface, there's a little see all button. We do tend to hide those just for simplicity of interface. If I want to grab out all of these, because this is a lot of references, some of the other classifications I've looked at have been 1, 2, 5. I'm going to highlight this export report button here in the very bottom left. When I hit that export report, what it will actually do for me is go ahead and list all of those conveniently and concisely along with the criteria that they're supporting. So in this way, I can just, download this, take this information, and go to my clinical report. Again, I'm just trying to highlight different pieces of information that we show you. The next variant that I have is actually one that Mark showed as part of his presentation. I'm not going to, as he went through the classification and how our team did that, I'm not as much going to highlight that information or concentrate on that information. What I am going to show you for this variant, though, is something that Mark mentioned. The See Options button right here, this has been there for all of the different variants that I've shown so far. However, for this variant, there's actually a clinical trial recruiting. So this is where we really want to return comprehensive or sensitive information about every single variant. This could change, right? So this information could be useful for a patient. This patient could be eligible for that clinical trial. That information, again, is available right here through a link that says See Options. And if I were to, in this case, say, hey, I do want to, again, export that information for a clinical report, just like I showed down here in the bottom left corner, just like I showed for the last variant. In this case, now I'm also going to get out that clinical trial information. In this way, I may be able to put that on my report and say, hey, this patient could be eligible for a clinical trial. So that information has been available in the See Options. It's just for this variant particularly, or for this disease and this gene, there actually is a clinical trial recruiting right now. The final variant that I really wanted to go through here is another variant, another gene. When I actually put this variant into the search bar, you'll notice that it actually matches two different variants. So first, the variant I actually entered, match protein change, but the second here says SRD. That's shorthand in our system, just to show it in user interface, for this being part of the splice receptor on the donor side. Right, so that's SRD. I'm going to go ahead and add the variant that I added that I'm interested here. What you're going to see here then at the top is, again, I have this variant. When I go in and view that interpretation, I'm going to, again, get all the information, the evidence that I've been looking at. But you're also, again, going to see that key here, right? So that this is part of the splice receptor. In that way, not only do we have, say, functional change information, and again, the case information, so PS4 here, that we've been looking at the entire time. What you'll also see down in the bottom left here, in addition to the other prediction algorithms that I showed for the very first variant, in this case, we also are bringing in information about that splice impact. Right? We even have a single article down here that speaks to that splice impact on the actual protein. Right? In this way, there's even more information, right? So any criteria where we do have evidence, where we do have literature that supports any piece of information that I've shown at all on this screen, we'll actually add that. So it's not just for the criteria I've been focusing on so far here. I wanted to make sure to show one variant where there's additional information down here. We'll do the same thing when we talk about, is missense variant a known mechanism of disease? We'll actually put articles and references for those too, if they do exist. This is all about returning comprehensive, sensitive information for every single variant classification. We really want to show our work in every single different piece and show you that in order to gain trust for these classifications, they're easily reviewed by the end user. I can go over, I can view those different pieces of evidence. Right? So I can go ahead and review these articles that I just had, that our team also reviewed. I can look at the sentence fragments down here. And in another webinar that we actually hosted a little while ago, our curators go through how they use the different pieces of information that we have. For example, this filter categories. I can find those functional studies that the team was reviewing. I can find that information supporting PS4, so case studies, family type information. This is available in the software so that for variants where maybe we haven't done that interpretation event yet, or genes where we haven't fully interpreted all the variants in there, our professional users can use these tools to do that type of interpretation very quickly for themselves. So we have an entire webinar. I didn't want to focus on it too much today and repeat that. We have an entire webinar where our team goes through those different filter categories for exactly how they quickly arrive at these types of classifications, right, where they're quickly assessing clinical information, functional information, and then obviously these come from outside annotations. I think for right now, I'm going to turn it back over. That's all I really wanted to show today, and now we'll be able to go through the Q&A session.
Thanks so much. I'd invite everyone to turn their cameras back on. All right, great. And in the interest of time, I think we'll be able to address a few of the questions that we have. That was a fantastic presentation. Thank you so much, both of you, for sharing and giving so much great information. We had a couple of questions that came in from the audience. So I will start with Mark. How do you and will you address multiple conditions for genes when you're curating? If there's more than one condition, how is that approached?
Yeah, it's a great question. I'll begin by emphasizing that we have a whole team of folks in an apparatus or procedure that we follow. And when we curate these variants, the variants that are cited in any one of these references are couched in the context of the patients or the functional studies in which they were described. So the ENPP1 variant is a great example. ENPP1, as I mentioned, causes GACI. It also causes a form of autosomal recessive rickets. It also causes Cold disease, which is a skin condition, and there's two others that the names are escaping me now, but there's a variety of different diseases that are caused by variants in this same gene. And when our curators review that information, they catalog that. And Britt highlighted some of those disease annotations. They're tagged and they're reviewed in the context of those different diseases. That's particularly important when we're talking about reviewing this evidence for newborn sequencing. There's a large fraction of these genes that have multiple different disease associations, and knowing what disease is associated with what variant and by what evidence is critically important. So all of that information is annotated and accounted for in the curation and interpretation of these variants.
Excellent. Thanks. Thanks so much. And Britt, we have time for a question that I'd like to ask you. Are you incorporating ClinGen modifications into your curations? And if so, how are you incorporating those?
Yeah, so our team, again, not myself personally, definitely reviews and considers and potentially incorporates those modified ClinGen criteria. There are some, modified criteria like the adjusting of the support, the strength, which we're building into our curation pipeline. Many of the genes actually that we released were done in advance of some of those ClinGen criteria. As I mentioned, one of our goals is to make sure we keep this information absolutely up to date. So as we move forward, that's something we're looking into to make sure that we incorporate those potentially in the next round when we do updates. So for many, it hasn't happened yet, but we are looking into those as we move forward.
Okay. Fantastic. Fantastic. And I think I'll squeeze in one more question, again related to ClinGen. Mark, will ClinGen catch up and classify all variants? What is your take on that?
That's a good question, and I was presenting at ASHG, the live venue, and had a similar question. So just like we talked about ClinVar and Mastermind not being at odds by any means, they're complementary, and the integration of ClinVar into Mastermind is of great added benefit to the whole ecosystem. Similarly, there's value and merit in the ClinGen working groups who are focusing disease by disease on these different aspects. They assemble key opinion leaders, they review this data with great scrutiny, they set parameters and guidelines for how to interpret this data. You alluded to that in your previous question to Britt, and she answered it. What our approach is, we look at those criteria. I liken it to the Human Genome Project, where there was a public interest and a private interest, and they were both necessary. The chromosome walking, the plotting, what was deemed to be very scientific approach of painstakingly building out the scaffold of the sequencing versus the devil may care shotgun sequencing, which was ridiculed, but really materially drove the ball forward. So if you look at it through that lens, we are painstakingly and accurately and with human expert curation reviewing this data, amassing it computationally and reviewing it with our human curators. The work that ClinGen is doing is very valuable as well, but it's not scalable. It's going to take too long, and so I don't know that I would say they're going to catch up because we're not competing. I would say that there's benefit to both of our approaches. Sorry, I'm being attacked by the sun here. There's benefit to our similar approaches. We have scale on our side and comprehensiveness and all of the evidence predicate, and there's ways that we can mutually reinforce the benefit that we will bring to the communities. I will say that the pace of our curation is no more than a gene per week, even very, very large genes. With a small team of breakout team of our curators. So we're able to do this at breathtaking speed, ensuring the accuracy of this information compared to the many months or even 2-3 years pace of reviewing this information according to the ClinGen operating procedure. So again, there's value in what we're doing and what ClinGen is doing. They're mutually reinforcing them. And we expect to be have a critical mass of the genome curated in some few years here.
Okay, thanks. Yeah, that's definitely a difference. So Brittnee, I have a combination question for you coming in. How often, to switch gears just a little bit, how often are classifications updated, and how can someone find out when the gene that they work on is going to be curated?
Yep, this is a pretty common question we get. So how often are they updated? At least once a year. We are definitely going through, I think I showed, it was just beginning of last month that we had actually updated the classifications for ATP7B for Wilson disease. We had done that for the first time somewhere around April of this year. So that one only took us it was about 6 months that we did that update, but we are guaranteeing that that's going to happen, or we are saying that that's going to happen at least once a year. Obviously, that also depends on just the sheer volume of new articles for a variant. We want to make sure that if something is changing, we keep it more up to date than that. So that kind of gives you a long ballpark, and as well as the fact that we're going to be working to do that more often for variants where something comes out and that's could change the information. Built into Mastermind by default is actually the ability for a clinical lab, kind of turn this conversation, but built into Mastermind by default is the ability for a clinical lab to set that type of alert for themselves also. We had already built that where I can say for a variant or a list of variants that I've gone through in my lab and they're all VUSs, I can upload those to Mastermind and say, now proactively notify me if any new articles come up for these VUSs. We're using that capability in our system, that type of notification, to make sure our team is seeing the most recent any new publications. We're bringing online up to about 10,000 new articles a week, so that really can, over a lot of variants, have a significant impact. For the second part of that question, when can a person find out when their variant is being, or their gene, sorry, is being interpreted? Please feel free to write into support@genomenon.com. That goes to a team of us, including some folks on our curation team. We would love to hear what people are testing. As Mark has said, we're starting with these newborn sequencing. We're continuing down the path of doing other hereditary type diseases and genes. And, but we definitely want to hear if there's a large need in the field for a specific gene. We can take that information in as we prioritize.
Just to correct what might have been a misconception when I talked about the pace of our curation, I was referring to the time it would take to curate a gene. So it's very brisk. The smaller genes can be completed in a few hours with our curation infrastructure. Even the larger genes, the most they would take would be a matter of weeks. So just to be really clear, and to say that we are on pace to curate the genome in those few short years.
Wonderful. Yeah, thanks, Brittnee, for that response, and Mark for clarifying there. So we had a great discussion today about the impact of our work on newborn sequencing efforts. So I want to shift to ask a question related to that, Mark. Do you work with any of the patient advocacy foundations who are trying to get their genes on the newborn screening panels? And if so, how does our data actually help to support that work?
Yes, we do. In fact, we have a concerted outreach and engagement paradigm. As I mentioned at the beginning, we're a mission-driven company and people are central to that mission, the patients and their families being a central component of that as well. And so we have had a number of published engagements with those different foundations. Many team members have their own health journey that includes a rare disease diagnosis, myself included, and are actively engaged with the related patient advocacy foundations. And yes, we work together with the foundations, the drug developers, as well as those folks in our clinical diagnostic network to ensure that this data is maximally util. Our mission being to make this data actionable. And so there is a way to have us get connected with those foundations and the pharma and coordinate those efforts around the newborn sequencing pilots and related initiatives. And the disease GACI, and the gene ENPP1 is one such disease where we're working with the folks in those newborn sequencing pilots, as well as the pharmaceutical company Inozyme, who has developed the first in human trial for treating this disease with an enzyme replacement therapy. So that's just one example of several.
Okay, fantastic, fantastic. And it's exciting to see how the work can expand to support those efforts. Britt, I have more of a technical question. Someone is asking, what is the professional edition of Mastermind? So could you say a little bit about the professional edition?
Yeah, absolutely. So the professional edition of Mastermind enables the high throughput assessment of those articles that we talked about. Really, it's designed as a clinical support or clinical workflow. And what that means is the filters that I spoke about, where you can rapidly identify and prioritize based on our relevance algorithm, articles that speak about patients, about families, cases, functional information, right? So those types of filters and the ability to add additional information. When Mark went through sort of his chaos to ordered slide where he talks about the ability to add phenotypes, we can talk about diseases, right? So all of those are part of our professional edition of Mastermind. The basic edition, however, of Mastermind is free. Any user can sign up for that. They can do any number of searches that they would like. They can start reviewing those sentence fragments. Again, they're not going to have the power of the clinical, the really clinical version of the software where they can highlight functional studies, but they can absolutely review those sentence fragments. In fact, they can see some of that disease-specific curated content. So some of these classification events, they'll also be able to see some of those, although some of that information is for paid version only, or for our professional version only. So professional is really meant for a clinical variant scientist or genomic scientist in the lab that is interpreting variants. The basic edition, so that's the professional. The basic edition is really meant for people that are doing a search here, a search there. Maybe I need a couple variants in a gene once every week or so. That's absolutely available in our free version.
Okay, excellent. And just to continue on the topic of using Mastermind to search, is it possible to search for phenotypes? I know we can look at gene variants, but is that also an ability that exists within the search engine?
Yeah, it is, absolutely. And again, that's part of that professional edition. You can add diseases, phenotypes. There's many workflows. In fact, you can come in with just phenotypes. If you really have a diagnostic odyssey, you can give us a series of phenotypes and say, now give me genes where authors have talked about my phenotypes of interest. You can do that in an and or fashion. So you can say, I have 5 phenotypes, I need it to mention all of these, or I have 15 and I don't know if it's going to be specific to any of those. We're going to give you back a prioritized list of genes that says these genes are talked about with these 7 phenotypes, right? So it can actually help as part of gene and variant prioritization. We even with our API, which we didn't touch on today, I won't, but even there we have scripts that are written where you can give us, say, a filtered short list of variants in several different genes and a list of phenotypes and say, please return a variant or 2 that best explains the phenotypes. So we can really do that type of variant prioritization, or again, come in on the somatic side, the workflow is a little different. I have a gene, a variant, and a specific type of cancer. Now give me therapies.
Thanks. Yeah, that's fantastic. So we're at time. Mark and Britt, thanks so much for sharing all of this useful information today. I think we've covered some really valuable insight for our users around using the curated genomic data for newborn screening and patient care, and in particular thinking about the disease-specific curated content. This has been a great discussion, so I'd like to thank everyone for watching today. As a reminder, you will receive a recording of our discussion later today, so look for that in your email inbox. Also, if you don't yet have a Mastermind account, that link was dropped into the chat, so you can just click it there and sign up to start your free trial of the professional edition for Mastermind. If you're currently using the basic edition, you can talk to us about upgrading to get access to these features that we just talked about and that you saw in the presentation today. And as always, if you have questions, don't hesitate to reach out to us at support@genomenon.com. Finally, please be sure to follow us on LinkedIn and Twitter and subscribe to our YouTube channel where you can find this recording eventually and many of the other webinars we've done. And with that, I will conclude our event. Thanks everyone for joining us today. Have a great day, and we hope to see you in a future presentation. Take care.
Thanks.